A new treatment of heart failure right under our nose. What if there was a new cardiac drug that could safely do all of the following? Improve coronary blood flow, improve systolic function, improve diastolic function, inhibit fibrosis, inhibit atherosclerosis, inhibit inflammation, reverse fetal gene expression, and reduce mortality without increasing the heart rate above normal? Well, I think there is thyroid hormones. It's interesting because this is a study published in 1951. 3 different groups of patients with ischemic heart disease. They showed a dramatic reduction in mortality with desiccated thyroid treatment. You can see this is kind of a young blue-collar group, white-collar group here, and this is a little bit older group. But you can see in each case, there's a very dramatic reduction in mortality from those patients that were treated with desiccated thyroid hormone. In another study with Barnes, he showed the occurrence of cardiovascular disease in 1,500 plus patients. Treated with desiccated thyroid was 94% lower than the Framingham data would have predicted. So this is an old story. It's been around for a long time. And why hasn't it translated to patient care? Interestingly, the main study that was a follow-up to these studies I just mentioned was the Coronary Drug Project. They used a thyroid component to treat patients that were metabolic patients, ischemic heart disease, but they treated them with DT4. LT4 is the active form of thyroid hormone. DT4 was an analog. So this, rather than follow through with desiccated thyroid that seemed to work in multiple cases, they, of course, couldn't make any money on that, so they had an analog DT4. Unfortunately, some of the patients developed arrhythmias, but if you look very closely to what they did, you will see that they were overdosed, not only overdosed with DT4, they later found that the composition was contaminated with a toxic dose of active LT4. So they clearly made these patients hyperthyroid, and certainly we know that hyperthyroidism can lead to arrhythmias. Then there was another study that was very influential too, a DITPA study done at the VA. And if you look and see what they did here, they, they treated with 360 milligrams per day of DITPA until they knocked the TSH level down to pretty much undetectable levels, below 0.02. They had some benefits, but they had an increase, patients had an increase in heart rate, they had more diarrhea, they lost weight. This was clearly another overdosing study, again with an analog. So there's this fear of overdosing that really drives this area. The other thing too is the financial incentive. T3, T4 are pretty cheap generics. There's no money to be made, which kind of drives all the analog research so they can try to figure out a way to make more money. But, in reality, clinicians do need more information. Should you use T3 or T4? Can cardiac T3 be restored without inducing hyperthyroidism? I'll get to that later. We found that all of our animal models of heart disease that we've tested, all heart disease seem to produce a hypothyroid heart, low T3 in the heart. Probably true in people too. Hasn't been confirmed yet though. But how would you know in a patient without doing a cardiac biopsy? What are the long-term effects? There's, other than the early studies that I just mentioned previously. So there's a lot of questions, even someone who is very much on top of the literature. But what struck me is I think the biggest roadblock to this is there's this general belief that thyroid hormones cannot be done, treatment cannot be done safely. There's this general belief that there may not be a therapeutic window. And the reason I know that is if you look at the people who are doing thyroid analog research, in the introduction, they often say that you can't use thyroid hormones because they're too toxic. There's this assumption that there's no therapeutic window. So I'm going to get to this a little bit later because we have that's one of the things I really address. So what does low thyroid function do? Well, we know all types of heart disease, ischemic heart disease, hypertension, idiopathic dilated cardiomyopathy, all lead to fetal gene program re-expression, which is what hypothyroidism does. And of course, if you look at the older literature, hypothyroidism leads to a dilated, thin-walled, dysfunctional ventricle, essentially heart failure. And there are isolated cases, occasionally you see almost every other year, of a patient diagnosed with heart failure, found out they were hypothyroid, treated them, and they were cured. And we know that there's a whole bunch of, there's just a ton of papers that have been shown a link between low thyroid function. For instance, if you have a myocardial infarction, you tend to get low T3, serum low T3. The greater the reduction in serum T3, the bigger the increase in mortality. There's a couple of review articles we did recently, one in Circulation and one more recently in American Journal of Physiology, that goes over all the clinical information and the basic science information. But this is just in the last year, this year, in 2015. I just did a little search to see what has been published about patients just in 2015. This study showed that T3 and T4 are reduced in patients with dilated cardiomyopathy. This study showed an increased severity of heart failure and worse short-term outcomes in heart failure patients with type 2 diabetes. This study showed increased mortality in dilated cardiomyopathy patients with hypothyroidism, subclinical hypothyroidism, but not hyperthyroidism. So low thyroid function clearly linked to increased mortality. In this study, they showed preoperative hypothyroidism as a risk factor for postoperative atrial fib in cardiac surgery patients. This study showed hypothyroidism was 300% more frequent than hyperthyroidism in patients with AFib enrolled over 10 years. But some studies don't really show a link. Why? I think part of it has to do with serum thyroid hormones likely underestimate cardiac T3 levels. The heart only gets about 4 or 5% of the cardiac output, and by the time that is mixed with peripheral blood, you've got about a 20-fold dilution. So that might be one of the reasons why, if it's specific to the heart, you don't really pick up a cardiac tissue hypothyroidism. And there's really no available information for thyroid hormones from coronary sinus blood in heart failure. That would be helpful. Animal studies, again, as I mentioned, show that all these types of heart disease we looked at, MI, hypertension, diabetes, they all show low tissue T3s, and in some cases the serum may be completely normal, even though you have a hypothyroid heart. So this study, basically, it was pretty clear to me a few years ago that no one had ever really shown definitively that hypothyroidism by itself can lead to heart failure. So we did a simple study. We've made rats hypothyroid for a year. Sure enough, they were dying of heart failure by that point. They had a dilated chamber, a thinner wall. Even though the heart mass was reduced, they were more dilated than controls. And the damning thing here was they had series addition of sarcomeres. So the myocytes were elongated. And of course, hypothyroidism unloads the heart. But in this case, even though it unloads the heart, you have actual dilatation. You know, Ken Margulies' group showed that with the LVAD, you can actually reverse remodel a failing heart with series removal of sarcomeres if you unload it. So clearly, this is very much of a heart failure phenotype, severely impaired coronary blood flow, and some extensive changes in the microcirculation. In this study we published a few years back, we treated animals. These are a model of dilated cardiomyopathy, a TO2 cardiomyopathic hamster. They usually die about 10 months of age of heart failure. We treated them with thyroid hormones for 2 months, and from the point of treatment, they had impaired coronary blood flow. These animals actually had subclinical hypothyroidism. But basically it prevented the progressive myocardial fibronecrosis. It even tended to reverse the fibrosis, completely prevented the progressive loss of cardiac myocytes, and restored coronary blood flow to normal. Now, does this happen in people? Is there any evidence impaired coronary blood flow occurs in humans with non-ischemic cardiomyopathy? And I think the answer to that is yes. There's some studies done by Ruhr and other people where they did PET scan. Now, of course, there doesn't seem to be an incentive to do radioactive technique to look at coronary blood flow if the patient has patent coronary arteries. You know, you pretty much declare that patient non-ischemic. But in the few studies that have done that, they found impaired coronary blood flow. It looked like it was at the microvascular level. And there's another study here that was kind of interesting. They looked at non-cardiac patients who had subclinical hypothyroidism, and they had impaired coronary blood flow that was restorable by normalizing thyroid hormones. So what about the risk of arrhythmias? Here's a study we published in Circulation Arrhythmia recently. We looked at hypothyroid, euthyroid, and hyperthyroid animals. And what we found was that the incidence of atrial fibrillation was certainly high in the hyperthyroid animals, but also just as high in the hypothyroid animals, and the duration of the arrhythmias lasted longer in the hypothyroid animals. So this suggests that low thyroid function is also very much proarrhythmic. Then we looked at myocardial infarction, and we found the MI animals, we could induce a pretty high incidence of atrial fib, dramatically inhibited by a low dose of T4. And this was associated with reduction in atrial fibrosis, which has been linked to arrhythmia. So the thyroid-treated animals had a significant reduction in atrial fibrosis. And we more recently confirmed that with a very low dose of oral T3. Same thing, we had a high increase in arrhythmias, inducible arrhythmias in the MI animals, and dramatic reduction in the T3 treated animals. This is with a very, very low dose of oral T3. So the question is there a safe therapeutic window for thyroid hormone treatment of heart disease? I decided that this is really a question I needed to tackle with animal models, because this is what's really, I think, been impeding this whole area is people don't think that you can do this safely. So we decided to try to do this as reproducible as possible with human models. So we did oral T3, and we published this study with hypertensive rats that we treated for a year with 4 micrograms per kilogram per day. And it turns out that they had overt hypothyroidism by the time we got to that 2 years of age, which is a pretty old rat. But it restored the cardiac tissue T3 levels. It inhibited the fibrosis. Now, these animals still had severe hypertension, but they were treated with thyroid, and it reduced the systolic wall stress. There were very strong trends for reduction in diastolic wall stress too. Tau was reduced, and diastolic pressure almost reached significance. If we hadn't had to kill some of these animals because they develop old age tumors, I'm pretty sure we would have had significant changes there. But anyway, this is interesting because there's no treatment for diastolic heart failure that's effective. And this study suggests that just a tiny low dose of T3 may actually target some of those things like myocardial fibrosis that might help to improve diastolic function. This other study, we looked at, again, 3 micrograms, a low dose here. These animals had a diabetic cardiomyopathy, and this dose completely prevented all the heart disease. They literally had no heart disease. It reversed the fetal gene expression to normal. It prevented the fibrosis. It prevented systolic and diastolic dysfunction. It turns out their serum was completely normal, thyroid hormone levels, but the heart was hypothyroid. The T3 levels were about 35% below normal. So, and that low dose completely restored the tissue T3 levels, and literally they had no heart disease. They still had diabetes, but they had no heart disease. More recently, a study just completed, we treated MI rats with 5 to 8 micrograms this dose. That improved LV function and improved survival of myocytes after 2 months treatment. So I think the answer to that question is yes, I think there is a therapeutic window. Cumulatively, all of our studies there showed that a dose between 3 and 8 micrograms per kilogram per day in rats, it might be slightly different in humans, but those doses, that range was clearly a therapeutic window that didn't increase heart rate. Now, when we got above 8, oral dose of 8, some of the animals started to show an increase in heart rate, and some started to drink more water too, and that of course made them consume more thyroid. But below 8, they drank a normal amount of water, and we were able to show this therapeutic window between 3 and 8. So, and what you look for within this therapeutic window is a slight reduction in serum TSH and probably T4, some reduction in T4, but we really didn't see any change in serum T3 levels unless they were below normal to begin with. It restored serum T3 levels back to normal in those cases. So I think this is an approach that we could very safely use in humans. It's a very small dose, and so during my talk here, there's been about 50 people in the world that died of heart failure, just in my talk right here, and I think we could take patients with hypothyroidism, subclinical hypothyroid, low T3, and safely treat them legally now. But what's missing here is we don't have a serum biomarker to tell you that the heart is hypothyroid. This is something that we're kind of working on trying to identify, because you could safely treat about half of these patients with end-stage heart failure because they have all these evidence of low thyroid function. But what about people that are normal serum levels that may actually have a hypothyroid heart, like our animal studies show? So that's something that we clearly need. I should say that, you know, one of my colleagues in China, who's deputy director of cardiology at Fuwai Heart Hospital, I asked him about a year ago, why don't you just take these end-stage heart failure patients that everybody's given up on? You know, they send them home to die. So if you're on optimum therapy, we can't do anything for you. And he decided to go ahead and start treating some of those. And he's got some funding from a company in China that does T4. I think ideally it'd be better to use something with T3 in it too, but one thing that was really shocking to him, that with these end-stage heart failure patients, he found that half of them had overt hypothyroidism. Half of them had overt hypothyroidism, hadn't been tested for years. And I suspect that's happening in our country too. Now you're talking about a hormone imbalance that by itself can cause heart failure on top of whatever their other diagnosis is. You know, so to me that seems pretty negligent. He was really kind of shocked that it was that bad. And so he's starting to treat those patients. It's like they all say they feel so much better within like a day or two. They can't believe how much better they feel. Every one of them, they can't believe how much better they feel. So I think when we tell these patients that there's nothing we can do for them, there probably is something we can do for them. Okay, I think I'll stop at that. Some of the people helped me with this work. Thank you.